Welcome to this iLearn video with Dave Windsor, ITU and anaesthetic consultant. Dave is going to talk to us about end-tidal CO2 waveforms.
Hello, so we're going to talk a little bit about end-tidal CO2, where it's useful for paramedics, and in particular what we'd like you to know from it and what we'd like you to achieve by using this with your patients. End-tidal CO2 can tell you not just about CO2 placement, but it can also tell you more about what the heart and lungs are doing, and we can use that to guide how we treat these patients. So we'll talk about the CO2 waveform first of all and what you'd expect to do. Obviously we're using CO2 to give us an indication of tracheal tube placement. So it's a binary, is the tube in, yes, no. If it's in, we should get a CO2 waveform and we should get a good waveform. We should say that obviously in your patients, post-cardiac arrest, the waveform might not be as good as we would see in anaesthesia. We'll look at a classic waveform here. Now, end-tidal CO2 is a trace of the waste gas as it's being expired. And what you see in a classic trace, if we look at our scale here, this is time along the bottom, and this is CO2, usually measured in kilopascals along the top. And a normal end-tidal CO2 for most people will be about 5. So what you'd see when somebody inspires first of all, so when you inspire no CO2 is produced, and then as you begin to expire there is actually no CO2 produced for the first part of expiration, because that's most of your tracheal gases coming up. And then you see a waveform that looks something like this. And this is as you get mixed gases coming out from both your alveolar and your trachea. And then as you're just expiring gas coming out from your alveolar, then you see a plateau. And that's what we see in a classic waveform, which is classically thought of as 3 or 4 different phases. So just running through this again. End of inspiration, beginning of expiration, mixed gases coming up, and then you should see a nice level plateau as it comes in. And then this point here is where inspiration starts again, and you see no CO2. If you don't see a CO2 trace, there's 2 reasons for that really. One, your tube may be in the esophagus and not in the correct place, so you should always be thinking, have I intubated the esophagus? The other question is, to generate CO2 you need a cardiac output. So you need to make sure you've got a cardiac output. Now in your patients, post-resuscitation, one would hope they have a cardiac output, but even just CPR will generate some CO2.
Thanks for that, Dave. And could you talk to us a little bit about that normal trace and then what an abnormal trace would look like?
Yeah, so I think what we need to keep in our minds is what a normal trace looks like. And like I say, the key values being a gentle upstroke, and there is a slight slant up to a peak at the top and then coming down. And then if we look at some of the more abnormal traces we may see, so the first trace we want you to be able to recognise is no CO2. So no CO2 must make you think, is this esophageal intubation?
If you see this when you ventilate following an intubation attempt, you must remove the tube and reoxygenate your patient and consider your next step to achieve effective ventilation.
Or have we got no cardiac output? So we may have no cardiac output because of some blockage in the heart of the lungs or ongoing resuscitation. And if you're seeing that trace, you're not getting good enough cardiac output. During arrest, you should be looking for a trace similar to this. Now, the perceptive of you will notice that it's a slightly lower trace, and we're not getting the same level of CO2 back at that 5 level we had before. So that's a low CO2 trace. The waveform itself is good, but you're seeing a lot lower levels of CO2. So that could well be reduced cardiac output. And in this case, you may think about increasing the depth of your compressions, or if you've got ROSC, it could be that they're hypotensive, and you may need to be thinking about further doses of adrenaline. The other traces that are worth mentioning are here on the side, and hopefully you can see the differences. This is 5 at the top here. First trace is in the bronchospastic patient. This is something you may not see very commonly, and it may be a bit over-diagnosed because we do see it with people intubated. Again, there may not be much you want to do in the management, but a recognition that actually this slow upstroke, if you see, that's very different from a normal trace, which would be a more rapid upstroke. And that's because in the bronchospastic patient with narrow airways, they've got a slower expiration as because you hear them wheezing, and you can anticipate that with this sort of trace. And that's what we see in the bronchospastic. So what you'd be thinking about there is your pre-hospital care, doing nebulizers, potentially IM adrenaline in somebody who may have arrested through asthma. The final trace I want you to just appreciate is this one, which is what we call a hypercapnic trace. So this was hypocapnic, low CO2. This is hypercapnic. So there's many reasons for hypercapnia, which you can look up. But the predominant one is when we're seeing too high peaks, way above this 5, this could be 8 or 9, that we may be underventilating the patient. So we can either ventilate with a larger tidal volume or a higher respiratory rate. And that should bring us back to just remind us of the more normal trace of where we are. Is that helpful?
Yes, that's brilliant. Thanks very much.
Now let's look at connecting the equipment. Firstly, take the Autofus monitoring unit and find the end-tidal CO2 port. Connect the end-tidal CO2 analysis unit to the monitor using the port. Next, take the sampling line and insert the lance into the end-tidal CO2 analysing unit. When correctly inserted, a green light will appear. Connect the sampling line to the T adapter and tighten gently. Due to the risk of the sampling port getting blocked by secretions, it is advisable to insert a filter into your airway circuit between the patient's lungs and the T adapter. Connect the filter to the catheter mount and the BVM to the T adapter. You are now ready to connect the equipment to your patient's iGel or ET tube.